So my presentation today is going to focus in on recurrences and C. diff infections. And while a single episode of C. diff can be very devastating, it's a cycle of recurrence that truly defines that burden of disease on both the individual and our healthcare system. So I'm going to take a moment to just do a brief overview of the C. diff landscape, much which have already been presented by earlier presenters, share some new data about the pathogenesis of C. diff recurrence, and discuss perhaps if that new data can help us break the cycle of recurrence. So I am an employee of Nestle Health Science. I'm the National Director for the field medical team. And this slide deck was developed by the Nestle Health Science. Please be advised that the information provided herein is intended solely for educational purposes. It is not intended to replace professional medical advice, diagnosis, or treatment, and healthcare providers should use their clinical judgment and expertise when interpreting and applying the data within. So these statistics have been gone over several times this morning, and so I won't reiterate it, but we know that the CDC defines a recurrence of C. difficile as a new episode within 8 weeks of the original episode. And with each recurrence, the risk of further episodes occur and trapping individuals in this relentless cycle, truly affecting their life and patient outcomes, as we've seen shared by the patients that have shared their stories today. The impact of repeated C. diff infections cannot be understated. We've heard the voices of the patients who shared their stories today. It's this continuous cycle of suffering that deeply affects their lives. And beyond those physical symptoms, they experience anxiety and depression. Simple activities like leaving the house can become very daunting, not sure where they'll find that restroom if they need it. There's also this real concern about transmitting the infection to others, which adds to their emotional burden and social isolation. So recurrent C. diff is associated with increased morbidity and mortality. Individuals suffering with C. diff are more likely to be hospitalized, face complications, and have a higher risk of death. The economic burden is significant. Repeated treatments, frequent hospitalizations, increased costs for the healthcare system, and there's a tremendous amount of financial strain on the patients, as we've seen the patients here share in our stream. So this has gone over earlier as well, so I won't kind of belabor what causes a recurrence, and we'll jump, get into the data. Paul Fureth did a great job of talking about what the current guidelines are. So this is just kind of a large schematic that kind of puts these guidelines together. So it summarizes the recommendations that are currently in place. It includes the 2021 IDSA, SHEA, and ACG guidelines that were established before there was approval of the FDA fecal microbial therapies. And it includes also the AGA guidelines released in 2024. So I'll have you focus on the circled area. That really is talking about recurrence. And Paul went into great detail about the guidelines. But suffice to say, the guidelines right now are not clear on the optimal timing for using FDA-approved fecal microbiota therapies to prevent recurrence. So I'd like to take a look now at the pathogenesis of recurrence to determine if there are differences that would warrant different treatment approaches. So to do so, I will review the findings from this study by Bryant and colleagues, comparability of gastrointestinal microbiome and bile acid profiles in patients with first or multiple recurrent C. diff. This research compares gut microbiome and bile acid profiles between patients experiencing their first C. diff recurrence with those with multiple recurrence. And so hopefully this will enhance our understanding of the underlying pathogenesis. This post-hoc analysis is derived from ECOSPOR-4, which was a phase 3 open-label study of an investigational product, fecal microbiota spores live BRPK, now marketed as BOUST. The study involved 263 patients with recurrent C. diff divided into 2 cohorts, 29 participants from ECOSPOR-3 who had developed a recurrence within the first 8 weeks, and 203 de novo or new participants, all with at least 1 episode of C. diff. The study objective was to assess differences in gut microbiome of the bile acid profiles between participants with first recurrence, noted as rCDI, versus those that had multiply recurrent C. diff, noted as mrCDI. The analysis group included only cohort 2, with 77 participants in the rCDI group and 186 in the mrCDI group. Stool samples were collected at baseline, which was defined as within 3 days following the completion of the antibiotic treatment for the qualifying CDI episode. Additionally, participants were asked to provide an optional stool sample 1 week at post-treatment. So to evaluate the microbiome composition, baseline stool samples were collected before treatment and analyzed using the Shannon Diversity Index, which measured both species richness, which is the total number of species, and species evenness, the relative abundance of each species within that community. Additionally, a dose species richness test was used to measure the amount of spore-forming Firmicutes. The first graph shows baseline Shannon diversity scores for the FR-CDI group, which is noted in green, for the MR-CDI group, which is noted in orange. And you can see that there are similar low scores. The second figure illustrates the species richness, again, showing at baseline low levels in both groups. In the dose species graph, you may note that the FRCD group was slightly more than the MRCDI group. The numerical difference here was small, the interquartile ranges of overlap indicating limited clinical significance. But overall, as you can see, at baseline, there were no significant difference from the FRCDI group versus the MRCDI group. Here, as we examine the post-treatment results at week 1, both groups demonstrated a significant increase in all alpha diversity metrics, including species richness and the Shannon Diversity Index from baseline to week 1, with a statistically significant difference. For the dose species richness, robust engraftment was observed in both groups, as indicated by the number of newly appearing species at week 1. So in summary, at post-treatment, week 1, there were no significant difference between the groups, first recurrent versus multiply recurrent, in terms of magnitude of change in the microbiome composition, diversity metrics, and number of newly appearing species. Next, we're going to look at the bile acids. And I think earlier we've had several discussions about bile acids and how they affect the gut environment. So bile acids serve as an indicator of gut environment, influencing whether it's conducive or inhibitory to C. diff outgrowth. Primary bile acids promote C. diff outgrowth, and secondary acids suppress. The bile acid analysis here revealed no significant difference between the groups at baseline for both primary and secondary bile acids. The box and whisker plots on your right illustrate that there was initially a high level of primary bile acids, followed by a decrease in concentration at post-treatment week 1. And the secondary bile acid concentrations that were low at baseline and significantly increased. So to kind of summary, this microbiome analysis illustrates a common pathogenesis for FRCDI group versus the MRCDI group. In both groups, there was impaired microbial diversity at baseline that improved after treatment. In both groups, primary bile acids were high at baseline and decreased after treatment. For the secondary bile acids, the levels were low at baseline and increased after treatment. Both the FRCDI group and the MRCDI groups had similar rates of C. diff recurrence at 8 weeks. So these findings suggest that there's no significant difference in pathogenesis between first recurrence and multiple recurrences. And this raises the question of whether a treatment approach should differ between these two scenarios. So as I close, I want to emphasize 3 points. To effectively reduce recurrence of infections, it's crucial to address the underlying gut dysbiosis. This approach will help break the relentless cycle of repeated infections. Treatment strategies should consider the similarities in pathogenesis. And is it time to consider treating earlier in this disease cycle? And lastly, healthcare providers often rely on practice guidelines for clinical decision. It's important to keep guidelines updated to reflect treatment strategies, helping healthcare professionals stay informed and being able to ensure their patients have access to all available care options. So could you envision a world where recurrent C. diff infections are a thing of the past? And thank you.